Good evening and a warm welcome on behalf of MSD. I'm Dr. Suchita, the Oncology TA lead for MSD India. So we know that the role of immunotherapy currently the academic coordinator for Department of Medical Oncology since 2022 and has got the membership of the all important international societies. Our second speaker is Dr. Akhil Santosh, who is a consultant medical oncologist in MVR Cancer Center and a special interest in the GI, breast, GU cancers, and some of the achievements is MRCP, the academic credentials from MRCP UK London, the RCP and ECMO. So thank you so much for accepting our invitation. And without delay, I would like to give a floor to Dr. NK Warrior for the context setting. Thank you, sir.
Good evening. Finally, we could get some audience. Initially, when I came here, I thought it will be purely a online meeting, though it is described as a hybrid meeting. Anyway, good evening and welcome to this today's webinar. And I am standing on behalf of ISO and MSD combined webinar. The focus of discussion will be on the adjuvant treatment of high-risk renal cell carcinoma and the various factors that will influence the outcome. So this topic brought me the memories of my initial days when the treatment for renal cell carcinoma was dismal, and the outcome also is very, very poor outcome. And always when somebody is diagnosed with renal cell carcinoma, it used to be a death sentence for them. Then started with treating with the interferons, then interleukins, with the minimal response, and then TKI came in early part of the century, and then subsequently the era of immunotherapy started in its own way. Now, when we reached 2025, we see exponential growth in the various molecules in the immunotherapies coming to the picture, and all the more the scene is complicated now. So without wasting further time, I invite Dr. Srilesh for his first talk on evolving role of adjuvant immunotherapy in resected renal cell carcinoma. Over to you, Srilesh.
Good evening, everyone. First of all, I would like to thank Warrior Sir for this invitation. Also thanking the Indian Society of Oncology and MSD team for giving me this opportunity. So what I am going to discuss today is regarding a very important topic, an evolving topic, the role of adjuvant treatment in patients with renal cell carcinoma, especially with immunotherapeutic agents. So when a patient with renal cell carcinoma comes, so first thing is to do a staging workup. So basically, if you see a localized disease, the treatment is very simple. You do surgery, either a radical nephrectomy or a partial nephrectomy, depending upon the size as well as the location of the tumor. And when this patient comes to medical oncology, say 1 year back, our job was very simple. Just keep the patient on follow-up. We don't need to see anything. We just need to see whether the metastatic work has been complete or not. So the problem is some of the patients, especially those with high risk, and there are many predictive factors or prognostic factors like stage. So stage 3 is going to progress or relapse fast compared to stage 1. Likewise, you have some other factors like grade, Fuhrman's grade, like grade 4 is going to have a bad outcome compared to grade 1. Then necrosis, presence of necrosis is a bad factor. Similarly, a sarcomatoid type of histology in the specimen, that is also a bad. And there are multiple models. So this is basically a retrospective registry from the Mayo Clinic for the last 30 years. So they compiled data of around 300 patients, 3,000 patients, 2,100 patients, and they found out certain variables like tumor grade, tumor size, tumor thrombus, extension beyond kidney, age more than 60, all these considered as a bad prognostic factor, both in terms of progression as well as for the survival. And also because of that, there are various predictive models to predict the risk of recurrence. So even though we usually don't use till now, we may have to use in the future because this high risk predictive things need to be done. So basically there are lot of predictive models like the UCLA, SSIG and Mayo model. So basically, this is basically for the clear cell RCCs, and they basically include various factors in the form of TNM staging, tumor size. Some of them use performance status, some of them use venous invasion. So there is no consistency in this. So if you take an example, suppose you have a T3 grade 3 tumor. So if you put in this UCLA scoring system, so you have a localized RCC. If you are planning to have a risk stratification, the T3 grade 2 in the UCLA, the performance stat is one of the factors, good performance. The 5-year survival is around 80%. That is pretty good. Suppose if you again put in another scoring system known as SSJEGN, which has got more factors in the form of necrosis as well as tumor size, the same patient, the survival goes into 38% 5 years. So it is not consistent. So almost 15 years back when I was doing my DM, the main treatment for metastatic RCC was TKI, either in the form of sorafenib or pazopanib. So there has been multiple attempts to improve outcome in adjuvant setting by using TKI. There are so many using different TKI, the Assure trial, Atlas trial using axitinib, you have trials, but unfortunately everything failed. The only trial which showed some positivity was the adjuvant sunitinib 1-year trial, that is the extract trial, which showed a DFS improvement. So again, these are the details about this trial. So you can see, so almost all the trial failed in OS. Only one actually succeeded in showing a DFS improvement. But nobody practices it because it is highly toxic. If you see the toxicity grades, you can see almost 100% of the patients will have some form of toxicity. And grade 3, which is very significant for an adjuvant setting, you will have around 60%. The treatment discontinuation is in the tune of 40%. So it is very difficult to give adjuvant TKI, and also there is no benefit. So this is not practiced. So what about immunotherapy? After TKI, in metastatic setting, the immunotherapy era came, either in the form of IO-IO combination or IO-TKI combination. So there are various, when a drug is found to be useful in the metastatic setting, they will incorporate into the adjuvant setting. So here the concept is that if the patient, when a patient with a RCC comes to the clinic, usually there is no role of any neoadjuvant treatment. Usually patient comes after surgery, especially in the localized setting. So it is found that the concept is that your surgery, immediate post-operative period, there is an immunosuppression thing happening. Mainly because you are inducing a surgical trauma, there will be loss of blood losses, there will be various interplay of cytokines. So ultimately what happens is that immediately after surgery there is an immunosuppression. So basically this is the concept, this is the reason why they took this immunotherapeutic agent into the adjuvant setting, so that if you block that immunosuppression immediately after surgery, that may be beneficial. There are many trials, but we are going to stress on the Keynote 564 because it is the only trial which showed a better improvement in the DFS as well as overall survival. So Keynote 564 design is patient with clear cell RCC. The importance is it is only for clear cell, more than or equal to 18 years. Patients were included were high risk of recurrence. So basically 3 groups: high risk, intermediate high risk, as well as M1 NDD group. So patients should be started on treatment within 3 months of surgery, randomized between pembrolizumab for 1 year versus placebo. The primary endpoint is DFS, secondary endpoint OS, and various other quality of life measures. This trial was powered for both DFS and OS. So so if you see the risk group, so which are the patients they are defined as risk groups? So we have intermediate high risk, which are basically T2 with grade 4 or sarcomatoid histology, or any T3, that is intermediate to high risk. High risk is either node positive or T4. And M1 NED is basically patient undergoes radical nephrectomy, and within 1 year patient develops a METS, that is oligomets, and you resect that METS. So that patient comes as M1 NED. So these 3 groups are included. These are considered as high risk for recurrence groups. So this is the ASCO GU 2024 update, where you can see a pretty improvement in the DF, disease-free survival, with a hazard ratio of 0.72 with a good confidence interval. This is positive for DFS. And also the best thing about this is that it also showed a positive overall survival, which has never happened in adjuvant kidney setting. You can see in 2024 ASCO GU, the trial showed a positive absolute difference of around 5% with use of adjuvant pembrolizumab for 1 year. So this is because you can see the hazard ratio of 0.62 with a good confidence interval. Again, subgroups almost all the patients benefited, and especially the highest benefit was for those patients with intermediate high risk, and those patients had the maximum number. You can see around 855 patients. And of course, you are actually comparing with placebo, and you will have slightly increased toxicity in the treatment arm, but you can see most of the toxicities were grade 1, 2, like fatigue, pruritus, hypothyroidism, diarrhea, and grade 3 side effects, especially diarrhea and rash, was all very minimal only. And also most of the side effects happened within 6 months of treatment. Again, there were also secondary endpoints for the quality of life. Again, you are comparing with a placebo. Again, if you compare the placebo, the quality of life measurement was almost similar. So if you just look at the subgroup of patients with the East Asia population, again there is a numerical improvement in the better DFS as well as OS, but even though not statistically significant because numbers were very small, 58 in each group. Again, you can see the survival curve. This is the intention to treat population where there is an improvement in survival, but in the East Asian group, there is definitely numerical improvement, but there is no statistical significance because of the low numbers. Again, when a trial, especially in the adjuvant setting, shows a survival improvement, you have to see what is the treatment that the placebo group received during progression. And if you see the trial, you can see that pretty good number of patients actually received subsequent treatment in the placebo arm. You can see immunotherapeutic agents were given almost 70% of the patients. So basically in terms of subsequent treatment also, the trial did a very good job. Another important concern is, suppose the patient receives an adjuvant pembrolizumab and after unfortunate patient again progresses, what will be your treatment of choice? So patient undergoes a nephrectomy, relapse happens. So next question is whether the patient received adjuvant pembro or not. If the answer is yes, then look at the progression. If it is a oligoprogression, then you can consider some local therapies and you can just follow up and wait for the frank progression. If there is a frank progression, then the question is when was the last dose of pembrolizumab given? Suppose if it progresses during treatment or within 6 months, you can use TKI. And if it is after 1 year of last dose of adjuvant pembrolizumab, you can use the IOTK or IO arm in the first line metastatic setting. Between 3 to 12 months, actually there is still, we don't have answer, but it is up to the clinician to decide which treatment to be given. So there are a lot, so we know that this is the only trial which showed a positive DFS as well as OS. So in your practice, whether you incorporate it into your clinical practice or not. So basically there are other 3 trials. One is the Checkmate 914 trial, which basically used combination of nivolumab plus ipilimumab for 6 months. Again, the inclusion criteria is more than or equal to T2 group with grade 3. Only clear cell histology, but the DFS, it was not positive trial. Then using adjuvant atezolizumab, again 1 year duration, again high risk patients, again negative. Then Prosper using adjuvant nivolumab, 9 months duration, again negative trial. In the Prosper they used other histologies as well. And also the group of patients included were very small tumors as well. This is the only trial which showed a positive DFS and OS. Why 917 failed? There are lot of debates, because if you see the 914 trial which used nivo-IP, almost 43% of the patient in the treatment arm discontinued treatment, mainly because of the toxicity. So 33% discontinued due to toxicity. And in fact, even there were some 4 deaths in the adjuvant arm, which never should be happening in an adjuvant trial. Again, in the nivolumab, that is Checkmate 914, there is another arm just using nivolumab, again for 6 months. Again, this trial did not show any benefit. Prosper trial using adjuvant nivolumab for 9 months. Here, one arm is nephrectomy. The other arm is a nivolumab arm. Here the 1 dose of nivolumab was given prior to surgery, then the rest was given after surgery. And in spite of that priming dose of nivolumab, because like we always speak, we need to have some intact tumor for the immunology to act. Even giving that priming dose of nivolumab, the trial was actually negative. The second question, so it is not going to be beneficial for all patients. So can you just find out which are the groups of patients that is going to have beneficial effects? Is there any molecular factors? So PDL1 is widely used in lung, but in kidney it is not standardized or it is not validated. Then TMB, again we don't have any data even for the metastatic setting. Sarcomatous histology, like you see in metastatic setting, if you have a sarcomatoid histology in the Checkmate 214, which showed an excellent long-term outcome with nivo-IP. So in the adjuvant setting, again we don't know. The newer molecular, blood-related parameters are coming up, like KIM1 protein. So basically this KIM1 protein is a blood glycoprotein which you can measure in the blood. So in previous retrospective analysis, it has been found that in the ASSURE trial using the adjuvant TKI, if the patient has got a high KIM1, that is kidney injury molecule, in the blood post-nephrectomy, they are going to do badly. So this can be assessed as a prognostic marker for kidney cancer. Similarly, in the adjuvant atezolizumab trial, you can see that if you have a high KIM1 positivity in the blood after nephrectomy, they are going to have a very bad prognosis. So this top one is the KIM low group. The top one is the KIM low group, and the down one is a KIM high group. So we have seen that the adjuvant atezolizumab is not associated with any benefit, but if you look at the subgroups, those with high KIM1 group in the post-operative period, those patients actually the atezolizumab benefited with a good statistical value. But those patients with a low KIM1 group, the benefit was not there. So basically, this can be assessed as a biomarker, but still it is not standardized or it is not widely used. The third important thing is whether, suppose you see, nowadays we recently had 2 to 3 patients with a stage 3 papillary carcinoma, whether you recommend adjuvant pembrolizumab for those patients. Actually the answer is not yet. There is a trial going on with this adjuvant pembrolizumab for stage 3 papillary RCC. So once this report comes, we can use if it is a positive trial. So always look at the histology. Then last one is the exclusion criteria. So when a trial is reported, we always look what are the inclusion criteria. So if you see the 564 exclusion criteria, those patients who had a residual disease were excluded. So if you have a residual disease, you treat it like a metastatic disease. Similarly, if the patient has got a active autoimmune disease that required systemic therapy for the last 2 years, again they were excluded. So the use of adjuvant pembrolizumab in patient with autoimmune disease, in metastatic setting we can take a risk, but in adjuvant setting we better not to take a risk. Similarly, if the patient has got some immunodeficiency syndrome like chronic glucocorticoid therapy, they were also excluded from this trial. So again, these points to be keep in mind. Then again, the US network analysis also showed widespread use of pembrolizumab in the adjuvant, especially in the clear cell histology. So this is just a poster presented. So again, is it the end? So you can see there are so many trials going on in the adjuvant space using durvalumab in one arm, durva-tremi in the other arm, and also they are also nowadays using the pembrolizumab with belzutifan as an adjuvant protocol. But these are all actually recruiting patients. Again, we know from melanoma data that when you are using an immunotherapy, giving neoadjuvantly is the best approach, but we don't have any data in kidney yet. So this trial is actually testing whether neoadjuvant use of pembrolizumab is going to have a benefit. Again, these are recruiting trials. This is a phase 2 trial. Again, there are also vaccination, mRNA vaccination coming up. So this is another trial known as Interpatch trial, which is a phase 2, again using pembro with some mRNA vaccines in the adjuvant setting. So conclusion, so we should offer to a patient who we think that it's a high risk. We have to explain the patient that there is an option of using adjuvant pembrolizumab for 1 year, and it is associated with an improvement in overall survival as well as DFS, disease-free survival. So, but always carefully individualize the patient. Patient should be discussed about the risk benefits of the current uncertainties, because some immuno-related adverse events, especially in the form of adrenalitis or hypothyroidism, is going to be permanent. Again, comorbidities should be assessed, and usually it should be started within 3 months after nephrectomy. So it should not be given to patients with a very low risk of relapse, especially T1 or T2 grade 3, and patient who has got some residual disease post-surgery. So these patients should be treated like a metastatic disease, and also patient with other histology, because we don't have that data yet. So I think I will finish this. Thank you.
Now, I think we will keep all the questions at the end of discussion. Now, Dr. Akhil will be talking on navigating the data insights from Keynote 564, subgroup analysis in adjuvant RCC.
ये वो डेस्कटॉप पे वो नहीं है, वो नहीं है सर। आप तो वो मेल कर दीजिए ना ये ईमेल आईडी पे।
बोलेगा JITHUM.RAJ 0333
वो अपडेट
gmail.com।
क्योंकि सर यही जो आपने लास्ट जो दिया था ना, यही था सर, ये वाला। ये आपने जो भेजा था ये
Okay, वही है क्या?
हाँ सर
Because my credentials, everything I put it in there. So you can see the finals.
it's the same.
Yeah, okay, I think this is the same.
It's the same.
Yeah, 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 yeah. Okay, you've changed the template. Oh, got it, got it.
full
Yeah.
screen कर
Full.
दिया.
Good evening, everyone. At the outset, I would like to thank ISO-MSD and Dr. Varya for giving me the opportunity to present tonight. Unfortunately, my topic is almost pretty much the same, and the slides are also pretty much the same. So let me try to discuss it in a different manner. Yeah. So, as you all know, kidney cancer, it ranks around 14 most in the incidence and number 15 in the leading causes of death. So, as you all know, RCC, it is the most common type of adult kidney cancer. It accounts for around 85% of all kidney tumors, and of the RCCs, the most common variety, as you all know, is clear cell, which accounts for around 70%. So this is as per the Globocan 2022 data, where the yearly incidence was around 15,000 odd cases and deaths of around 8,600. So I think among the Asian countries, India is one of the leading in the incidence of RCCs, almost the highest in India, but it's still lower compared to the West. So this is a very important slide. You can see that the risk of death, so it was significantly higher in patients who had a recurrence. So this is the reason why we should explore more adjuvant therapies in detail. And the death rate also, as you can see, it was 6 times higher among patients who had a recurrence compared to those without. So these were a slew of the failed adjuvant TKI trials, so that had taken place before. So as you can see, the only one with the DFS improvement so far, as Dr. Srilesh had discussed, is the STRAC trial, which had tried sunitinib for 1 year. So the main drawback of these trials were the higher incidence of grade 3 toxicities and the increased percentage of dose discontinuations, amounting to the tune of around 40 to 50%. So again, Assure, they tried both sorafenib and sunitinib, again was negative, as well as SOS and Everest. Just two takeaways. In the PROTECT trial, where they tried pazopanib, the dose that they used was 600 mg. When they had tried a dose of 800 mg, it had a slight DFS benefit. Also with the Everest trial, where they had tried everolimus, so in the patients who had the highest risk of recurrence, those subgroup had benefited. So, but these are very small groups. So the entire trial, as you can see, it is negative. So yeah, so what are the ideal qualities of an adjuvant therapy agent? So basically it has to eradicate local disease, it should lead to a survival benefit and very little side effects, and improves the quality of life. So you can see that the TKIs, they have ticked the first box, to a certain extent the second, but no to number 3 and number 4. So this was a survey which we had taken among the patients. So what the patients generally, their perception is that they're willing to accept a few side effects, but in the longer run, if that therapy can give them a DFS and an OS, they are willing to accept these minor side effects. So let's come to the trial in detail. So I won't be going into the minor details. Dr. Srilesh already discussed it. So as you can see, the trial, this was run by the DFCI group from the United States, led by Dr. Shawnee Shuri. So basically they have taken patients more than 18 years of age, exclusively clear cell, non-clear cell varieties were not included. And they have categorized it into two different subgroups, basically the intermediate high and the high risk. So basically the intermediate to high risk patients, they were your T2 grade 4 onwards, then T3. And your high risk patients, they were T4 disease, your M1 NED and lymph node positive cases. And the sarcomatoid histology. So the sarcomatoid histology, it accounted for around 10% of cases, and the percentage of lymph node positive, it was around 6% in Keynote 564. Basically, they were randomized to pembrolizumab for 1 year. The duration is important because, as Dr. Srilesh had mentioned, there were few adjuvant trials which had tried a shorter duration and failed. So this was for 1 year versus placebo. And again, the stratification factors are important. And another important factor is DFS was the primary endpoint and not overall survival. So I'll explain it in the end why this has got a bearing. So these were the overall survival results which was published last year in NEJM. This was following the ASCO GU 2024 results. So here you can see that the trial at a 4-year landmark, it had a DFS benefit. The median DFS, it was not reached in both the populations. And the hazard ratio was around 0.72 for DFS. And the median OS, again, it is not reached in both, significant this time. This was a third interim analysis, by the way. So the HR was around 0.62. And you can see that pretty much all the subgroups had benefited. And coming to the safety, as you can see that the grade 3 to 5 adverse events, they were very much less compared to the other trials. And you can see that around the ones which were attributed to the treatment per se, they were around 18%. Again, if you see the specific immune-related adverse events, so a quick glance at this slide, you can see that the major side effects like your nephritis, hepatitis, encephalitis, they were pretty much less. The major side effects were your endocrine, your skin toxicities, which could be easily managed. And one more important thing is your requirement of high-dose corticosteroids. It was also very less, only in around 6 to 7%. And yeah, so this, I want to draw your attention to the third, the rightmost portion. This was the third current interim analysis where I had discussed before. The OS hazard ratio was touching around 0.62. So there was a 38% lesser risk of death or progression. So coming to certain subgroups. So UISS scoring, it is basically derived from a retrospective, it's basically a retrospective predictive model. So basically they have grouped patients into intermediate and high. The factors that they used was your TNM staging, the grade, and the PS. So based on this, they have divided it into high and intermediate. And so this was the predisposition of patients in Keynote 564 as per the UISS staging. So you can see that around 73% were intermediate. So in Keynote 564, compared to around 20.5% were high in the pembrolizumab arm. And you can see that the majority, more than 50% of patients, they were T3, grade 3 to 4 in both the arms. So you can see that the drug, it benefited patients both in the intermediate high and in the high risk group and in the M1-MVD. So one important thing to note is that you can see that even though the numbers were pretty less, the benefit, it was the highest in your M1-NED subgroup. So this finding was the same compared to your atezolizumab trial also, IMOTION 010, where the risk of, the hazard ratios, they were the best in that subgroup. Also, yeah, so coming to, as you can see that the drug had benefits in stage 3, stage 4, your T2 grade 4, T3 grade 3 to 4, and your T4 N0 M0. So the benefit was less in your AGCC stage 2, but again, numbers are small. So again, you can see that the 5-year DFS, it was around 80% in your intermediate to high, 55% in your high risk, and around 20% in your M1-NED. So these are the latest European Association of Urology recommendations. So as per the results of 564, so basically you give adjuvant for any tumor with a T2 grade 4 onward, or with a sarcomatoid differentiation, or with T3 and any grade, and your high risk patients. And so again, they say that if your adjuvant therapy is planned, basically you have, because since this is the only trial which had a positive result, so you need to discuss the rest of the options, the rest of the contradictory results also with your patient before you make a shared decision making. And again, you need to discuss the results regarding your over-treatment and your immune-related adverse events. Over-treatment, I will come to the last slide. So again, the last point is very important. So basically, do not offer immunotherapy combination to patients with recurrence within 6 months of adjuvant pembrolizumab. So we have 2 landmark trials which support the same. So basically, they were CONTACT-03 and TiNivo-2. So basically, they have seen that both these trials, they assessed whether adding immunotherapy to patients who have progressed on a prior immunotherapy regimen, they benefit or not. So basically, CONTACT-03, they tested the addition of cabozantinib to atezolizumab versus cabozantinib alone. So basically, they have seen that there is no added benefit of atezolizumab. The same thing in TiNivo-2 they have done is they have taken tivozanib plus nivolumab versus tivozanib alone. Again, they said they found that addition of nivolumab, it does not have an additional benefit. So these are the again, I've already discussed the same, the indications of the adjuvant. There's nothing new in this slide. So yeah, so I just need, so I've discussed 564 in detail. I need to highlight certain points regarding each of the failed IO trials. So let us take it one by one. So coming to IMotion 010. So IMotion 010, actually the trial design was perfect. So they did everything right. So they took a huge number of patients. The sample size N, it was almost, it was the highest for Keynote 564, closely followed by IMotion. Again, they gave the drug for a good duration. They gave it for 1 year. So that was also tick. So, and they had taken the patients with the highest risk, just like Keynote 564. So they have taken M1 NED patients. Actually, the percentage of M1 NED and your lymph node positive patients, they were higher in the IMotion compared to Keynote 564. Then why the trial failed? So basically, if you go back to the original Lancet paper, what they show is that the drug per se. So basically, anti-PD-L1 is an inferior, they say that it is an inferior drug compared to your anti-PD-1, especially when it comes to RCC. So this, you have 2 trials in the metastatic setting where they have studied avelumab plus axitinib. So that was the Javelin Renal 101 trial, and your atezolizumab plus bevacizumab. So that was your IMotion 151. So you already have 2 failed anti-PD-L1 trials in your metastatic setting, and probably that might be the reason that IMotion had failed. So coming to the next trial, next we have Checkmate 914. So basically this was a three-arm trial where they had taken patients post-resection to adjuvant Nivo plus CP versus Nivo alone versus placebo. So we currently have results published of the cohort A only. So cohort A is basically nivolumab plus ipilimumab. Here again, there were a few concerns. One was the incidence of grade 3 for toxicities, your dose discontinuations, and another is the duration. So they say that in a disease like RCC, where your risk of recurrence is actually a continuum and it persists for around 1 to 2 years, so giving a drug for 6 months duration might not be the ideal way to go. So there were a few concerns raised regarding 914. And again, 914 also had very few non-clear cell patients also. And coming to Prosper. So Prosper, the design was perfect. Rationale was also mind-blowing. So you basically, when there is a tumor intact and you're draining lymph nodes intact, you give 1 to 2 doses of priming IO followed by surgery, and again you continue the IO. Again, but the duration, again, it was 9 months compared to higher duration in the other trials. And another issue they quoted with Prosper was that the number of doses of this neoadjuvant immunotherapy. So if you can see your landmark trials in your testing your peri-op IO, whether it be your lung or your breast or in other conditions, they've given it for 3 to 4 cycles. So here they have stopped with just 1 cycle. So they say that this one that would have caused the decrease in efficacy. Also, the trial design was an open label design, and this trial was conducted during the COVID pandemic. So it was open label, so many patients, when they came to know that they were in the neoadjuvant instead of getting a surgery, so there were a lot of dropouts, and there were like a lot of uneven dropouts between both the arms. So these were quite a few issues with Prosper. Yeah, so I think covered, I think, everything. Yeah, 2 trials upcoming. One is the Lightspark 002. Basically, they're combining belzutifan plus pembro versus placebo plus pembro. The results are awaited. And again, Rampat, so which is like a stride regimen, Durva plus Tremi versus placebo. The results are highly anticipated. Yeah, so I've talked about Keynote 564, great trial, great drug, only trial with OS results. So I just want to want everyone to read this paper. So this was a JCO. It was not an editorial. So this came in the comments and controversies section in 2022 when the initial DFS results of 564 had come. This was authored by the legendary Dr. Ian Tannock. So I'm just highlighting 4 points here. So basically they say that what are the attributes or what are the qualities of a good adjuvant trial? So basically, your primary endpoint should be your overall survival. So, and if it is your DFS, if your primary endpoint is if it is your DFS, coming to point number 2, there always arises the risk of informative censoring or your uneven loss of patients. And again, coming to point 3, did your control arm receive the optimum, the adequate therapy, or which was a standard of care? And coming to number 4, and if this was the only positive trial among a group of other negative trials, then again it needs to be looked at with greater scrutiny. So these were the 3 or 4 points that it raised. So again, I just highlighted it in a box. So basically, your control arm should be perfect. The surrogate should be your OS. There should not be any informative censoring, optimal post-progression therapy, and your consistency with your other studies. So let's just see what's written in the box there. So this was a major issue that arose when the initial results were published. Basically, there were a lot of uneven dropouts in the initial results. So basically, a lot of patients were censored. So there was informative censoring that was going on. And when they reran the sensitivity analysis after so basically they didn't know what happened to this group of patients. When they rechecked the analysis, excluding these patients, the results were not that positive, did not come out that positive. So again, but with longer follow-up, the trial, I agree that it had showed an OS, but this was raised as a point initially when the primary DFS results were out. So again, this was a beautiful editorial in Nature Communications. So again, I just want to highlight to that box over there. So basically they say that the number of patients who didn't progress in the placebo arm, it is around 50 to 60 patients. So that means that 1 out of 2 patients is actually not benefiting from pembrolizumab. I won't say benefiting, it's actually doing harm to that patient. I mean, the patient would have done better without pembrolizumab. So what does this suggest? It means that all this retrospective predictive biomarkers like your UISS and your the UCLA staging prognostic systems, they are not adequate, not at all adequate. You need better biomarkers. KIM1 is a good start, but you need more genomics, more precision methods and more improved biomarkers to predict which are those patients which will actually get the benefit from your adjuvant pembrolizumab. And that is also, one more issue was that around 1/3 of patients in the pembrolizumab arm also had progressed at this 4-year mark. So you need to find out those patients before so you can target them better. So again, this I think Dr. Srilesh has already covered. Basically, how do you treat your post-progression patients? Basically, so divide them into 3. Your refractory patients are the ones who are progressing before your adjuvant therapy ends. And then for those patients, there is no other option. So you know the results from TiNivo-2 and Contacto-3, no IO. You switch them to TKI alone. And for early recurrent diseases, 3 to 12 months, kind of like a gray area. You may give them a TKI or an immune checkpoint inhibitor plus TKI. More than 12 months is a late recurrent disease. You can be, rest assured, you may try a immune checkpoint inhibitor for these patients. Yeah. So I think that is it. Yeah. Thank you. Yeah.
So now the topic is open for discussion, and why don't you sit there so that everybody can bombard you with the questions. So one of the major point of discussion is about the trial Keynote 564, where the primary objective of the trial was only DFS. Then the OS benefit later found out that the trial carries some OS benefit. So what are your thoughts on that, Suresh?
So basically in oncology, especially in the adjuvant setting, the most important thing is overall survival. But for me, I think DFS is also good, sir. Because in the adjuvant setting, we need to give only 1 year of pembrolizumab. But once they become metastatic, the treatment is continuous. So in a resource problem countries like India, I think we should also, because we will get only one chance. Suppose if the OS is actually true, we should give. Even though it's a secondary endpoint, we should give. Also in metastatic setting, I feel even response rate is also actually good. Actually, suppose you give some drug and after 3 months patient comes, you don't see anything in the scan, patient will not be motivated. So every endpoint is important. But in adjuvant setting, I think OS should be the best thing.
Probably that is the one which, especially when in the adjuvant setting, we need to give only for a year, and when it comes to the metastatic, it's life, or at least 2 years, and then if there is good, excellent response. But one
The problem is there is another statistical analysis in this trial because the number needed to treat, if you see all these statistical calculation, the number needed to save one patient is actually 23. So you had to actually give 23 patients to save one RCC. So that is the important problem here. The NNT, that is number needed to treat for OS, is almost 23 patients.
So you were talking about when the analysis about the placebo, the 50% of patients were never, they never developed metastasis. That means the 50% of the patients were cured with the surgery alone, and probably immunotherapy, especially the Pembro, would not have made any difference at all, or in other terms, it's a kind of an over-treatment. So what is your...
But as I said, that you're over-treating 50% of the patients basically. So you need to find out which are those patients who will benefit the most. So the current biomarkers that we have with us, we are just using the TNM and the grade, and the Fuhrman's grade and your histology and TNM, that is it. So there is basically nothing else that features into your decision making. As of now, I feel it is inadequate. We have a long way to go. And the Kimon analysis from the post-hoc IM motion one, they were really good. So they basically had found a particular biomarker, the elevated levels of which would portend a higher risk of recurrence, and a clearance of the same would portray a better prognosis. So we need more such data. So we need more genomic precision. We need better single cell analysis, your spatial transcriptomics, and your finer details and better biomarkers to find out those patients. And also I feel that a drug is as good as its trial. So the Keynote 564, basically they had ticked all the boxes as I had mentioned before. They had taken the highest number of patients, they have given a drug for a better drug. In fact, an anti-PD-1 drug for 1 year, they had taken the highest risk of patients, and hence they had showed an overall survival benefit. So if the same thing was done for an adjuvant nivolumab trial, would it have showed the same benefit? I yet still don't know. Yeah, so that is out in the open.
I'll ask one, I'll discuss about real clinical scenario. We had a patient, 42-year-old gentleman. He's an engineer by profession and doing extremely well in his profession outside India. Diagnosed with metastatic renal cell carcinoma. He had about 3 centimeter tumor in the kidney, but the 2 lesions in the lung, which were only 2 lesions, which were doubtful initially. Then our surgeon felt that both can be removed, and then it turned out to be metastatic renal cell carcinoma. So what is your take, what is your advice if the patient comes to you? Patient, in short, metastatic renal cell carcinoma completely resected.
So this lung mets is in the same lobes or different?
The same
lobe. So in that case, I think I will go for a surgical thing. Like I will make it as an M1 NED, and I will give 1 year of
classical M1 NED. Yeah. So what is your advice on adjuvant then?
In that case, I definitely give 1 year of pembrolizumab, because basically it's a metastatic disease. And if you see that trial in the DFS, that was the group showing a maximum DFS. Numbers were very small, but survival benefit, I think there is no statistical significance there. Maybe because the patient definitely will progress. That time we may be in trouble because we don't have, sometimes the gap is, if it is very small primary resistance, we would have used TKI. So resect all this, 1 year of pembrolizumab and wait.
So this patient was started on pembrolizumab, adjuvant pembrolizumab. After 4 cycles, he developed cerebral vasculitis. And he returned back to India. We only advised actually, but he was taking Pembro from outside because it was reimbursable for him. So he came back and with the cerebral vasculitis. And then initially it was difficult to diagnose, but later they did biopsy and it got proved.
So this is a very, very dreaded situation, especially we use in the metastasis. So last week, Arun Warriors were saying one patient's adjuvant pembrolizumab developed myocarditis.
Yeah.
Patient died on the second day.
So that's a very tricky situation. So definitely, when you are talking about adjuvant treatment, it's a very important problem. So Sridharan, what do you think the adjuvant setting, keynote 564 showing DFS and clear, clinically meaningful DFS. That is what they describe about the keynote 564. So what do you think? So only. So are you convinced about the keynote 564, because all other trials were negative, and Akhil has beautifully described why they failed, and so. But by and large, we feel that there should be some treatment for in the adjuvant scenario, especially in the high risk group. Yeah, that's a thing. So the high risk, he was telling about the high risk. So some of the high risk features are very tricky sometimes, like especially the grade of the Fuhrman grade, and also the inversion, vascular inversion, and all other things. So in your clinical practice, what defines the actual high risk, other than what described? All these features, will you take it as a high risk feature, or only even among these high risk features will you select?
So T2 grade 4, I think it's a tricky question. T2 grade 4. But
so that is the so-called intermediate risk.
High risk. So
yeah.
T2 sarcomatoid, I think we should give.
Yeah.
I don't know what will, suppose it's a T1 sarcomatoid, I don't know what to do.
No. At the moment, there is no recommendation. Only the
node positive, definitely, like Sridharan sir said.
All the sarcomatoid they took were either T3 or T4. They did not have any T1 or T2 sarcomatoid in the trial.
There is a passing mention about the histology like sarcomatoid, recommended. But we don't know whether it is T1. But
yes, they have not mentioned that.
They have not mentioned. So 3 things they have mentioned. One about the size of the tumor, then the histology, and then the third thing is the ME and the M1. Totally resected. So when it comes to the adverse events, we talked about that. So that is one of the major problem. And then any other point? Any questions from the floor, sir? Yeah.
Favorable histology, which we expect that may fail. So thinking logically, I feel it should be included irrespective of the T status.
It is included, sir, but whether we are not sure whether it is the
T1 and T2.
Yeah, T1 and T2. That's small size and small percentage. So, so one more question, sir. The radiotherapy. Do you think the radiotherapy has got any role to sensitize immunotherapy? But not applicable for adjuvant.
We have not no idea about it because it has not been incorporated into any of the clinical practice so far. But I think it is a point which has to be explored.
So, yeah.
It is usually considered as a radio-resistant tumor, but what I understand is that if you can give high dose per fraction, like an SBRT
and
it will be good. But low dose, conventional doses, I think it is not going to work.
For unresectable diseases, also localized and regional, the trials are actually underway. They are combining SBRT plus adjuvant IU.
Yeah, that's.
So they have shown good initial results so far.
So what about neoadjuvant immunotherapy?
Basically, the problem is I never actually had a patient who referred to me for a neoadjuvant treatment for kidney cancer, because even if the tumor thrombosis is in the RA, our surgeons will remove it, then only comes. And also database, there is a neo-AVAX trial using avelumab plus axitinib, some 60 patients, but it's a feasible option, but it is not, I don't think there is any randomized phase 3. And I mentioned moon landing, some trial phase 2.
Neoadjuvant pembrolizumab.
Neoadjuvant pembrolizumab is trying, but we don't have any phase 3 neoadjuvant
Evidence to support.
Always there is a risk of progression when you're starting out with such therapies in a resectable patient. So that is another issue to be looked into.
So I think the adjuvant, almost all aspects we have discussed, but again the node positive disease may be a very good choice for adjuvant pembrolizumab.
That was another discussion we had in one of our previous meetings, because lymph node dissection, I don't know how many surgeons are there in the group. Lymph node dissection, it is not currently a part of the surgery. So if we are not incorporating a radical lymphadenectomy or some sort of a lymph node staging, then how will we find out those patients who might be deemed fit for an adjuvant therapy? So basically that is an area to be explored.
So from adjuvant we will move on to the metastatic setting where, so what is your current choice when a patient comes with the metastatic renal cell carcinoma? Say we have two group of patients. One group is having detected the disease totally asymptomatic but detected as part of screening program. Second one is really symptomatic and having multiple metastases. Both are having metastasis, but one is symptomatic, the other one is not symptomatic.
So if a patient with metastatic RCC comes, first we have to do that maybe in risk stratification, like whether it's a good risk, intermediate risk or poor risk. So if a patient with the de novo, I think invariably that will be in the poor risk or intermediate risk. So in a highly symptomatic patients, I think I would give IO plus TKI because that has got the maximum early cytoreduction and the response rate is very high, 60-70%. But problem with that is it is toxic. IO, TK sometimes can be toxic. Then there is another option is there IO, immuno, I think EVO-EP, especially for low volume, not very symptomatic patients. That is also a good regime, especially for intermediate as well as poor risk. Because that trial, there is even an option of treatment discontinuation. You will have a long-term PFS. But IO, TKI, invariably with time patient will keep on falling. Yeah. There is no tail in the curve as far as I know. Because the hazard ratio keep on coming down. But IO, I think there are certain patients, like especially with the sarcomatoid histology, 50% of the patients can have even a cure. That's my opinion.
So patients with a relatively lower tumor burden and were not that symptomatic, I would prefer an IO regimen, nivolumab plus ipilimumab. So the Checkmate 214, this is the trial with the longest follow-up, and recently we have published the 8-year results have been published, where actually the median OS was more than 50 months and the duration of more than that, the duration of response was also around 80 months, so more than 80 months. So, but the issue with that is if you're trying for a relatively symptomatic patient, your chance of early progression, that is high. So that is around 20%. So that is lesser with your IO plus TKI combination, and your CR rates are also very lesser compared to your other regimens, and your ORR. Your OS is higher. Basically, you get your good PFS2 and your OS and your DOR. So that is what you're achieving with a double IO regimen.
So Sridharan, what is your choice when a patient comes like this?
Asymptomatic patients, double IO is an option, especially because you are able to stop therapy. That is the only advantage that I see with that. We are going to use IO plus TKI, at least the TKI has to be continued indefinitely. So the other one can stop after some time. So,
or when you are selecting treatment for metastatic renal cell carcinoma, what all factors you will be looking at, right? Commonly when you
most important will be
the cost. Yeah. Affordability. Then other than that, Akhil, what all things you will recommend?
A regimen that I'm very much comfortable with is pembrolizumab plus axitinib. So one take from that study is basically axitinib, compared to your other TKIs, it has a very short half-life. So if your patients are experiencing any side effects, it is very easy to tweak the dose. So you can decrease, increase, you can titrate it, according to your will. And one more, good thing with this regimen is that when you're experiencing some sort of an hepatitis or your other query, your immune-related adverse events, so you might be confused whether it is due to TKI or it is due to an IO. So when you stop the drug and if the patient improves, you can be very well sure that it is related to this particular drug. So Pembro plus Axi is my go-to regimen if I am trying an IO plus TKI. The problem with your Pembro Lenva is that...
so in this context, let me ask you one question. A patient developed a complication, let's say hepatitis. So we stopped the treatment, and after 1 month, when the hepatitis got resolved, we started them on one by one. So like we started him on axitinib. Then after 2 months, we are in a dilemma whether to start pembrolizumab or not. So we have taken a CT scan which showed good response or continuing response. So in that case, what will you do?
I would raise that.
Pardon?
Actually, the guidelines say that in any grade 3-4 hepatitis, you're supposed to permanently discontinue. But it again.
So will you add IO or not? Pembrolizumab or not?
I would add.
You will.
I would add.
You will add.
I would.
Okay. So what is your opinion?
Any liver biopsy taken? Not biopsy.
No, biopsy was not taken, but.
Grade 3, grade 4 side effects, I think better not to add, sir. That's my opinion.
Especially in a patient who has responded very well, why should you add the
Add pembrolizumab.
I will not add.
Same thing had happened. We continued with the axitinib, and then plus minus progression in the radiologically. So we thought we will start, but by then there was some request from the family that they have a function, so they will start immunotherapy after the function. So when the patient came back after the function, we again had to do a CT scan because of some suspected respiratory infection, and then found that it got it didn't progress much, and the response continued. So we are just continuing with the TKI alone. So that also sometimes happens, and at least 1 or 2 patients whom we started patient on axitinib because they were not able to decide whether to go for the immuno or not. And it's very easy when you start axitinib, you can add immunotherapy later once they are primed. But we found that the patients are doing well, then we didn't go for pembrolizumab. One reason I can tell you as an explanation is some of them are, as you said, all this risk stratification may not be actually belonging to the intermediate or higher risk. They may be in the favorable risk group, and so favorable risk group even now. One of the options TKI, single agent TKI. So that may be the reason. And regarding the checkmate 214, it didn't do well with the favorable group.
Yeah, but they have also included it as one of the options in NCCN, and they have seen that with longer follow-up, basically the hazard ratio, which was more than 1 initially, so they are trending down. So they are coming, the latest one as per the 8-year results is 0.8 to 0.9. So they are, one of the favored options in your favorable risk.
Any particular site has got any preference?
They say that among the cross-trial comparisons, say that cabozantinib, it might be better in your brain and bone. The lenvatinib, pembro-lenva combination may be better with your liver mets. And I think these are the 2 groups where I can,
Any other thing, any preference other than the CNS? We don't do that.
Sarcomatoid histology, I think we should use IO combination, provided patient is not very symptomatic. So in that trial, sarcomatoid had a very good, I think, 60%, some DFS or something like that. We recently had a pembro axitinib patient who had a liver dysfunction. So it's a very tricky which one to stop. So we actually stopped the axitinib like Akhil said, axitinib has got a very short half-life. If the patient improves, we will think that it is axitinib. But pembrolizumab, half-life is around 21 days. So if the patient doesn't improve, we may have to do a biopsy. We have done biopsy, but pathologist won't report it like an IRA.
Yeah, correct.
The reporting will be different.
So which one is least toxic? The IO or IO plus axitinib, or IO plus lenvatinib, or IO plus cabozantinib?
Pembro-lenva actually had the highest toxicities.
Least toxic.
I think
least toxic. That is the question.
Okay, least toxic. Oh, nivolumab plus cabozantinib, I guess, as according to the other trials, they had a least
supposed to be
tox side effects.
Recommend dose for lenvatinib is very high.
Very high.
Exactly. And they say that if you're not able to maintain that dose of 20 mg, the responses might not be, survival outcomes may not be that good. If you're decreasing it to 14, 12, 10 and all, you have to maintain that 20 mg. It is very difficult in our population.
Okay, so any other questions? Arun, Sudha?
How will you define oligometastasis in a case of RCC? Is there any consensus?
I don't know. There is consensus is not. It's
Any
basically
definition?
Definition. Basically less than 5 mets, but depends upon the site also. Suppose you have 3 mets, one in the left upper lobe, right lower lobe. That will be difficult. So usually it is less than 5, I think. And also location also. Basically, it is an MDT kind of discussion. So whether your surgeon is comfortable, your SBRT team is comfortable, that is basically a theoretic, practical definition.
I think they have it specifically for renal RCC, I guess.
So any questions from anyone? So I think it was a nice interaction, and we have touched upon almost all aspects of renal cell carcinoma, though not in the agenda, but we discussed somewhat detail about metastatic renal cell carcinoma as well. So the take home from our side is adjuvant setting, in the adjuvant setting, especially the high risk renal cell carcinoma. The forum felt that there is a need for adjuvant treatment, especially in the wake of the Keynote 564 has shown excellent DFS, and also there are reports that the OS also will be good in the trial. I think that for high-risk patients, high-risk renal cell carcinoma, adjuvant treatment with 1 year of pembrolizumab should be the standard of care till we have any other contradictory trials coming. Till then, I think we will continue with this practice. And regarding the metastatic renal cell carcinoma, we have talked about how to choose treatment, especially the IO combination and the clinical settings where it is more apt to use IO plus, as well as IO plus TK for the specific indications. So with that, I will hand over the mic to you, Vijayam, and thank you all for the nice interaction.
Thank you, sir, for the excellent session. I especially want to thank Dr. N.K. Warrior, Dr. Shrilesh sir, and Dr. Akhil. I think 2-3 important points that I want to highlight after the session is, which takes, like, as I started, this is very, very important for the organization also, because India is a cost-sensitive market, and we definitely cannot offer a treatment to each and every patient, and it's very critical to identify the right patients so that we can enhance their overall survival. And I think today's discussion actually led us to that discussion, that which are those appropriate patients for the Keynote 564, where there is a optimum patient outcome. I take as a feedback for us also that there is we also are aware that there is not a good biomarker, especially in terms of adjuvant RCC. But as an organization, we are continued to evaluate the biomarker. Apart from that, there is the pipeline also, as sir highlighted. The organization has full focus on how the belzutifan can add value in RCC, and also we are very much focused on V940, which is one of the mRNA vaccine not only getting evaluated for RCC, but also for all other adjuvant settings like melanoma or NSCLC, which may improve the outcome in future for these patients. And special thanks for sir, that not only for adjuvant RCC, but a great discussion for the advanced RCC, where so important how we can choose between IO and IO-TKI basis the different factors. So I really want to thank the faculty present here, and also the audience who is physically present. There are 160 audience joined virtually, so I really want to thank them also for joining. And special thanks to the BioQuest team and the Mice Idea team. Thank you. I kindly request if we can have one group photo with the audience here. Thank you.